Thank you, Dr. Subhash. I would like to, at the outset, thank the organizers and the Chairman Scientific Committee and for this opportunity given to me. So I'll be talking on the update on the managing of childhood nystagmus. As you all know, nystagmus is a rhythmic, regular oscillation of the eyes. It may consist of alternating phases of a slow drift in one direction with a corrective quick jerk in the opposite direction, or it may be a sinusoidal to and fro movement on either side. As we classify them, we usually do it in a more clinical form. The physiologic ones like OK and caloric or the end gaze nystagmus, the pathologic ones as the sensory associated with poor vision, which may be having underlying retinal or neurological problems, or the motor which have neurologic disorders, and the childhood nystagmus which may be considered as essential infantile nystagmus. And there are some nystagmoid conditions which are not true nystagmus. So these physiologic nystagmus, all of you may be aware as the railroad nystagmus, the optokinetic nystagmus, which are used for testing, especially in a comatose patient. You may use the caloric test or the doll's eye phenomenon. The nystagmoid movements usually puzzle us in the form of Heyman-Bilchowski's phenomenon, or in the paranoid you may have a convergence retraction nystagmus. The acquired asymmetric vertical or oscillopsia present nystagmus needs imaging. Now this is something which is underlying. The details of these may be in different forms that you may have acquired nystagmus. These are there, you may keep in mind. So these are having underlying neurological lesions, and that's why imaging is essential whenever you have. So whenever a child presents with an acquired condition or an asymmetric nystagmus, like this child has an asymmetric nystagmus. So when it came to us, we got an imaging done and we found a lobulated suprasellar enhancing mass lesion which was there. So this can be life-saving if you keep this in mind. Otherwise, the nystagmus in childhood, you will have to see whether they are having associated poor vision, and if that is there, a complete eye examination, a fundus examination, and if necessary, electroretinography should be done. Those cases which have none of these usually are earlier known as congenital nystagmus or motor nystagmus. Nowadays, we use the term infantile nystagmus syndrome. There is another condition which we'll deal with, that is a fusional maldevelopment nystagmus syndrome. In the older books, it was manifest latent nystagmus. And the third variety is the nystagmus blockage syndrome in this category. Those which are marked in red, again, are to be kept in mind: spasmus Newton syndrome, seesaw nystagmus, vertical nystagmus, and acquired asymmetric, as we talked about earlier. All of these you have to do neuroimaging. Now this condition in which there is a to and fro movement on either side, if you record them, they will be like this pendular pendular nystagmus, and usually they have associated problems in the retina. So look into it and do necessary ERG or VER to confirm that. Those cases in which there is no such thing, usually the visual acuity is going to be good, and as you find this child, this is having a infantile nystagmus syndrome. It starts as a triangular jerk, to and fro movement, which are there in the early infancy, and later part of infancy it becomes formalized in the form of a pendular and then a jerk nystagmus. Usually they will acquire a head posture, and that is a very important thing. If you notice it, then you can correct it accordingly. Now this child is coming with a head posture. He has a right-sided AHP, and as you can see, there is a fixation of the eye, of the right eye. Now how do you confirm that? If you cover the right eye, he continues to have the left eye in abduction fixating. Now this is important to distinguish from an adduction null. This is a gaze null, and this is usually of the infantile nystagmus syndrome. Now see this another child who has again a similar right-sided fixation turn, and when I cover it the right eye, he is going to first, initially the nystagmus worsens, and then it again assumes the left adduction position. Now this is important to clinically differentiate, because these cases are manifest latent nystagmus, and usually the surgery in these cases is bimedial Farden. Now another adult person who is having a fusional maldevelopment nystagmus associated with intermittent divergent squint. Now when the IDS is latent, there is a phoric form, then there is no nystagmus, and when I break this, as you see now the IDS has broken, it becomes manifest, the nystagmus also gets manifest. So here the key thing is, if the strabismus is corrected, these cases can be converted to latent form. So Sciantia syndrome or infantile esotropia nystagmus in abduction cases, they will usually have a face turn to either side, whichever is the eye in adduction. And if that is there, if you are planning a surgery, always do an MR recession with a posterior fixation in order to correct the head posture along with the squint. That's what has happened in the second video. You can see the head is straight as well as the eyes are straight. Spasmus nutans you have to keep in mind. Now these children usually have a head nodding, torticollis, and also an asymmetric nystagmus. Now you see the left eye is having a larger abduction and frequency. Now if this is noticed by you, you should always do an imaging. So don't miss ever a child having a spasmus nutans. 80% of them will be benign, but you would not know which are the other 20% which may have a problem in the form of chiasmal glioma, like this child who has a chiasmal glioma presenting with that. Nystagmus blockage syndrome is another situation in which the eyes are straight when the nystagmus is there, and when the eyes assume an esotropia, the nystagmus gets controlled. So you have to correct the squint in these cases, and that nystagmus also can be corrected. So examination, just to remember, head posture for distance and near, look for associated squint, and any associated albinism is there in these cases. So this is what you have to keep in mind. Now measurement should be done for the head posture to find out how much surgery is to be done. Sometimes children would have a changing head posture or periodic alternating nystagmus. You need to examine them for at least 5 minutes in order to check for this PAN. If you miss it, you will have problems. In the non-surgical management, you have to do optimal prescription of glasses. Prisms are usually very limited role. Auditory biofeedback and acupuncture we have tried as research work, but they are only for short-term goals. Medical treatment in the form of baclofen, gabapentin, and even brinzolamide eye drops have been tried, but they are having a limited role at present. So surgery, we have the options of correcting the head posture by shifting the eyes to the primary position, and you can have this surgery usually done around 4 years of age, and we prefer the Anderson augmented Anderson's procedure, which is MR recession 9 and LR recession 12. Like this child, as you see, pre-op, his head posture, and after the surgery, it's got corrected. As also the ENG, electronystagmography, will show you correction. If you have missed a pan, you will usually have a face turn converted to the other side on the other day, and you would have to do augmented Anderson's of the opposite two muscles. So that's another advantage of doing augmented Anderson's, that you would still have an option of correcting the pan. If there is an associated squint, correct it, and that will help. Similarly, in the same principle, the chin up, down, or the torticollis are also corrected. And nystagmus surgery in the form of 4 muscle recessions have also been used, but they have limited role of 3 months, and the nystagmus usually turns back. Even artificial divergence surgery has been tried by people, but I would say that they have a limited role. So the take-home points are optimal correction. Cases with definite eccentric null up to 30 degrees respond very well to augmented Anderson's. For more than 40 degrees, do resections. Cases with pan, bilateral augmented Anderson's. Cases with fusional maldevelopment nystagmus, do a squint correction. The IENA Shansha, as I said, would require MR recession with posterior fixation. And cases with no definite null, you don't have actually a good answer. All these things have been tried, but not much use. Imaging has to be done in spasmus nutans, vertical seesaw, and acquired nystagmus. So with this, I would like to thank you all for a patient listening. Thanks.
Excellent presentation, sir. If anybody is having any question, you can go ahead. And I would like to invite
Sir, use the mic, please.
Pramod
I think everybody will be able to.
Before,
please give him a mic.
Yeah. Pandey, Dr. Pandey is here.
A mic.
Sir, what was your question?
Did you find any vestibular labyrinthine cause of nystagmus in your study? Vestibular or labyrinthine?
Vestibular labyrinthine lesions. Yeah. So they are coming in the form of acquired nystagmus, usually, and they will have a linear relationship of the slow velocity, usually. And if they have, this sort of thing, you would have to do either an ENT consultation. They may require treatment medically or sometimes surgical management.
The other one is, did you find any congenital or idiopathic?
Congenital, usually we are not getting any such things. Usually they are having a neurological acquired condition. Sir. Thank you, sir.
Just one thing
I wanted to
ask. is how do you decide whether to do an Anderson or the Kestenbaum's procedure?
So as I said, for up to 30 degrees of a face turn, I would do an augmented Anderson's. That means 9 millimeters of medial rectus and 12 millimeters of lateral rectus. I wouldn't do a Kestenbaum for up to 30 degrees. If there is more than 40 degrees, then I would do the same Anderson's plus resections. As I said, the reason is that if you have missed a pan and you have done augmented Anderson's, you can easily do the other two muscles. But if you have done a Kestenbaum, there will be a problem. You would have to undo the resections and then do a recession. So it's a complicated procedure.
I was just one question, sir. Without the VNG, is it possible to differentiate a saccadic intrusion with the nystagmus, like a pendular nystagmus versus a square wave jerk when you see the patient? I mean, just a subtle clinically.
Yeah. So without ENG, yes, you may clinically see that these are going to be irregular. Whenever there are saccadic intrusions, there will be an irregularity which will come. A smooth nystagmus will be a regular movement. So clinically you can feel that. But yeah, to have an academic thing, you have to do a recording, and not only just recording, then NAFX or nystagmus equity functions and all these elaborate things. Yes. Thank you.